Lisa. And before we open things up to questions and interaction here, I wanted to pose a bit of a hypothetical to the panel. Let's imagine you're sort of dealing with an older Korean woman as a client or patient. They've brought their daughter along. You've referred them to go and see another service and provided them with like a brochure or some written information about the service. And the daughter pulls out the phone and starts using a translation app, using the camera to translate the text. I was wondering, Vesna, from your perspective, what would you do in that situation?
This is where I need one. Thank you. I guess from the first port of call would be to acknowledge how important it is that the daughter's mother receives the most appropriate information. I would explain to her that within New South Wales we have a professional healthcare interpreter service which is part of the healthcare team, and that in order to be able to fully communicate and allow the mother and the daughter to participate in that conversation, that we would be either booking an interpreter for another appointment or booking an interpreter for telephone interpreting, and explain the fact that this will allow the mother opportunities to ask questions, which through the written form is not necessarily the ideal.
Mm-hmm. Eva, do you have anything you'd add to that?
Not really, except to say that really in the absence of a sort of a clear policy guidelines on the use of apps, I again would reinforce and highlight the risk of adverse events in using such unmonitored apps.
So if the situation was slightly different, what if instead of it being written information and you were perhaps trying to explain some medication that you're prescribing, and the daughter requests that you speak into the app, and that would enhance her mother's understanding, but the daughter says, "I'm okay." So would that change the way you respond?
I mean, here again, we're talking about even a higher risk involved in administering medication or instructions around the use of medication, and the risk of adverse events is much, much greater. So again, from a sort of a clinical, from an organizational risk management perspective, it is a rather risky business, and again, would discourage such use. Because this is happening in a healthcare facility, and again, ultimately there's potential for, great risk and liability, legal liability with that.
Mark, you have a clinic which is outside a New South Wales health setting, so you can perhaps speak candidly, but what would you do in that situation?
The second situation, I think I'd certainly discourage use of the translation app. I think it's not reliable. We use the telephone interpreter service because that's what we have access to. We don't have very much access to in-person interpreters. And TIS is very good at translating. It's obviously it's not really set up to be translating documents. I would be looking for translated material on what we were looking at together. In a half-hour consultation where we see people infrequently, it's not feasible to have what we can't afford, and it's not feasible to have in-person interpreters. This is the case for the majority of GPs in Australia who do have access to TIS, which is a fantastic service which my colleagues in Canada and the US and Ireland and England and New Zealand all are very jealous of. But it's not perfect, and it's the lack of a visual element to it is a problem, and particularly where you're trying to look at documents. People will bring medications, bits of foil with medications in them from overseas, and with even chemical names that don't make sense. So it's a real challenge.
Mm. It's interesting you mentioned that video aspect. And I guess one of the things I was wondering is there a role for apps or, in the video space for helping Auslan interpreting, for people who experience deafness or hearing loss? Does anyone on the panel have a thought about that?
We've got a student who's looking at that next year, but starting next year there's a student. I don't have any experience of that. I'd just like to comment on the video thing before I hand over the mic. I think, we don't have, unlike the Hunter, access to video interpreting, and I think Matisse doesn't currently offer that. However, all GPs have a computer sitting on their desk which is connected to the internet. So certainly that's a space that would be interesting to explore.
And I guess on that, it's happening in the private sector. So on-call interpreting, language loop are moving to video. And in Victoria, they've privatised a lot of the interpreter services. And so part of what I was, trying to get to at the end as well is, we've got to own it. We've got to own the apps and make sure it's using our translators and interpreters that are qualified. And we need to own the video and make sure that public healthcare can continue to provide the service and provide it efficiently, rather than allowing this go off to private companies, which is a great fear of mine, because of the cost, financial burden that our services are under. Our use is increasing and it is extremely expensive. Our interpreters aren't well paid, but they're paid a lot less in the private companies. So we need to sort of own it. In terms of Auslan though, we've just got to do it. We measure compliance of interpreter use on our facilities in Hunter, New England, every single facility, for outpatient, inpatient and emergency people that need interpreters against how many actually get interpreters. For inpatients, we measure the use of an interpreter just once in an inpatient stay, and we're on 60% compliance, essentially across our district. So every inpatient, every 10 inpatients, 4 aren't getting an interpreter at all. So that's the reality. We need to find ways that, we can actually get, face-to-face and video and telephone, sight translation happening that, really works. And it is easy for clinicians. Clinicians always will say they don't have time. I'm here now, I need the interpreter now.
I'm glad you've raised the sort of public admin and governance sort of dimension around a lot of that as well. Ben, do you have any thoughts based on what Ashley was saying? Some of the concerns about the arrangements and needing to own it, but also recognising pressure from private sector players and so on.
Yeah, I guess, they're all, what you're saying makes a lot of sense, I guess, but as you're talking about the sorts of challenges that agencies can face in using different kinds of technology from platforms, I think that there are, I think it's a very complex issue, and I think there are, at a broader level, there are basic questions of, do all health agencies, for example, do they have easy access just to the internet? Are all the computers up to date? There's all these sorts of technological problems and basic, like how fast is the internet in one agency compared to another. So there's work that could be done at a broader structural level around improving some of those basic levels of access for health agencies and community members to technology to access health information. You're talking about in an interpreting context. I guess my work's more around translation. So how agencies work together, I think perhaps in a partnership-based approach, so that people aren't siloed out, to try and find ways of engaging some of the bigger players around those sort of improvements to infrastructure. That may be one option that could improve more broadly access to information. That may help. But I feel like I'm starting to ramble a bit because my expertise is not in interpreting, it's more around the translation angle. Is that what you mean?
Yeah, no, I think that's good, and I'm glad you've raised translation, because I was going to ask Eva, what are some of your reflections before we open it up to questions that have been the big changes in translation of the past 10 years, and how does that sort of How will that unfold into the future?
I mean, in a more globalized world, it's the need to access information quickly and cheaper. The translators used to be to get paid much higher rate previously. Nowadays, there's so much budgetary constraints as well as time constraints. So in this world, of course, they need to rely on or sort of use or make benefit of the some of the computer-assisted program or translation program is very essential. So while I still have I have my reservations and I'm resistant to the use of Google Translate. I'm a big fan of some of the programs that rely on the use of saved data or phrases or preset phrases that in a way accelerates the process of translation at a cheaper rate. So I'm still a big fan of that, but as long as we engage translators, a translator or one or two to edit and review the content for accuracy and for coherence and to communicate the
humans
messages.
Are still at the
in a
centre
user-friendly. In Australia and especially in New South Wales, there is a big emphasis on health literacy and the need to communicate information in a sort of in a way our consumers and clients can understand. So I guess with all these technological advances and and Google Translate, disregard this aspect altogether. So again, we've got this issue to deal with. But in terms of translation, of course, we can't deny the fact that we need to rely more on computers and translation software and translation programs to improve efficiency and again to provide the service at a cheaper rate. But I would say as well, there is a need for more research on and to improve sort of translation software and programs.
I was wanting to reflect on what you were talking about, some of the nature of that change, the pressures for efficiency and so on. Vesna, I'm conscious that us outside the tent, we often do the bad thing and conflate translation and interpreting a bit, which are, of course, quite distinct activities. What have been your sort of insights and responses to what Eva's saying about translation? How does that play out similarly or differently in the interpreting space?
Look, I think that the first thing that needs to be acknowledged is that the New South Wales Healthcare Interpreter Service is a very, very unique model, both in Australia as well as in the world. And we're very lucky. We have a very robust model. We have, as my colleague had earlier said, there are 5 healthcare interpreter services. We've now been in existence for 42 years. So it's not like we arrived on the scene, just yesterday. We do a lot of work on and pride ourselves on developing our workforce. So we do, both translations and interpreting. We do site translations, we do telephone, we do on-site, we do video conferencing. So we provide a lot of in-service and training to healthcare providers that work with us. But one of the things that we do, and we do it very, very well, we do it better than TIS, we do it better than any of the private organisations, is we provide professional development for our staff. And we provide mentoring and we provide supervision. So we look at training needs analysis, we look at gaps within our service provision. So we aim to consistently improve our service, improve the understanding of the profession. When we talk about interpreting is the second oldest profession in the world. You work out what the first may be. People have always needed to communicate in every aspect. The written word is extremely important, but we know that it is very different, especially when we're communicating in a health setting. Translations are there to support, they're there to inform, but when we're communicating with people, especially in the health setting, it's really important that we do have that, human aspect. And we know, and we've spoken about today the complexities of, language, of communication, and so I don't need to go into all of those things. But in the last 10 years, what we've done extremely well is, I think, the developing of training, quality processes and assurance. But what we are also fearful of, the changes within the profession, and what that means for us in the future with our future workforce.
That segues nicely just before I hand it over for questions, and if people start putting their question hats on. How can we harness, I guess, some of that, recognise some of those concerns and harness some of, I think, the positive interest and energy in this room to constructively engage around the sort of use of technology that we've discussed today? I mean, are there any concrete things that you or anyone else on the panel would like to suggest?
I'll just very quickly before I pass it on. Look, I think that, technology is wonderful and we need to be using it. And we've incorporated technology into our everyday service provision with the way that we book interpreters, as an example. And we've got mobile apps that all of our staff and sessional interpreters have. And so technology is really important, but it's there to support the work that we do. And it's about communicating the benefits and the appropriate use, and going back to also what Ashley was talking about, getting that message out there to our policy makers and ensuring that things are done properly.
I would like to add to that to train our workforce, our interpreters and our translators on the use of technology to support the work they do. Because we often, even translators who are supposed to make use of all these programs and technology, they really fall short just because they have no knowledge of it, or they have no capacity to sort of develop. They haven't had the development opportunities to develop their skills in the use of technology.
That's a really good point. Ben?
Can I just thank you for your wonderful reflections. It made me realise that when I was reading through some of the studies that we looked at in our review, there's actually this rich history of technology use in translation. So ranging from, as I was saying in my presentation, from computers through to email, through to document through software, through to online dictionaries and so on. And it's just made me think to what you mentioned, that cost perhaps and the perception of cost is such a big driving factor in whether someone's going to choose to quickly grab Google Translate for a session, as opposed to actually think about, well, how else could we do this? There's cost. And I wonder the degree to which hype and big tech are contributing to that hype. And is that just simply something we need to keep in mind, as you say, when we're communicating? Would you care to reflect on that, like that sort of relationship between costs, big tech and hype?
Okay, look, that's a battle that we have every day, because we do have these pressures, and we also have people within our own government systems that lack understanding, and they have, knowledge of the big the big tech companies and the information that they're putting out there all the time. But it's in a space of its own. It's not within the context, and therefore there's a lack of understanding from that aspect. We're consistently dealing with the cost efficiencies and the cost of our service, and as Ashley said, our interpreters are paid very, very poorly. There hasn't been an increase in payment in a good many years. So it's about, again, finding that balance and trying to understand our environment, the requirements of the system, and come up with those arguments, and we'll consistently work on the arguments and work on developing new methods and new ways of working, and trying to take ownership of that, because we don't want somebody else from the outside coming to tell us what we should be doing. So it's about us being innovative consistently.
I believe as well, I mean, to add to what Vesna said, there should be some sort of, it should be driven from top to bottom. And there should be some, it should be a ministry-led sort of support programs, as well as executive in every district should drive the changes and should support the changes. And I believe, I mean, again, funding to drive the change is very important. So resources and executive support and an organizational as a whole support is really necessary.
And a lot of those familiar themes in capacity building of organisational response, leadership, resource allocation and so on. I might open it up now if anyone's got any burning questions they'd like to ask the panel. All right, well, if we could make it a brief comment,
Yeah, it
otherwise
is.
I'll Tony Jones it and say I'll take that as a comment.
No, it's a brief
So-
comment, and it relates. It doesn't matter. It relates to what you were just saying about how do we balance technology, costs, resources, etc. And I think what we need to do, especially in health. Yeah, but it's not working, is it? Okay. Sorry. The question is that we work for health, and health has got at the forefront patient-centred care. If we're talking about patient-centred care, then that needs to be an equation in all of those other things, because it's about respectful communication, it's about doing the right thing, and we focus on that, and we don't, and very recently there's been a whole lot of work done around organ donation, palliative care, etc., teaching people how to speak English and be sensitive in the English words that they use. So if we're talking about then a machine or a human choosing the correct words and trying to find the appropriate word, because I put all my interpreters through that training.
Yeah.
It's about that thinking of those sorts of aspects of it rather than just those three only.
Any thoughts or responses to that? So I think broad agreement. Experts agree.
I was just going to say one thing is you were talking before about, you gave the example very early on. I didn't want to comment because interpreting is an area of particular I don't have a lot of coverage over, but with the two ladies who came in and one person uses an app, the first thing that I flicked to was things like, what's that agency's broader approach to culturally sensitive communication at that age, principles like that. You sort of flick to those sorts of ways of thinking about it rather than deferring to the technology in that space. And because in a way there's an opportunity to have a conversation there with someone that has a level of impact. So rather than thinking about it just you focused on a device, I think it's more about stepping back and thinking, this is a relationship I have here with someone. Is it things like the health literacy teach back techniques? How do I have a conversation with someone that's going to help me with technology being a problematic agent in that context, if that makes sense? Because that way you get a balance going where you're not trying to put them down at the same time.
Right down to the absolute basic. How do you greet a person? Do you say hi? Do you say hello? Do you say good morning? Do you say welcome? There is a range of words that you've got to choose that makes that encounter patient-centred, makes the patient trust you, makes the patient welcome. And it's just hello.
They're great points. Now I'm conscious a few hands shot up. Ben, your hand went up, and there's another one up the back.
I was just wondering if Ash could comment on what kind of training was needed to enable the implementation of the telehealth consultations.
The video conferencing side, very little. That first 2-minute video with the cartoon one, there's a test site. You go on, use the test site. Everyone's got a mobile phone. The majority of you will have FaceTime or Skype or one of the social tools on it, and you click a couple of buttons and you're on. There's not really training around that. Where we really needed to work on things were the concerns, the risks, the arguments against why you can't do it, and the other arguments, the idealist arguments. And believe me, I'm an idealist. I want to have, the best public system we possibly can, that everyone can get everything they need all the time. There's the views and the arguments that, well, you should have a face-to-face appointment with your doctor, and you should have it in a convenient amount of time, and there should be no wait list, and there should be no waiting time in the outpatient area and all of that, and there is. So it's arguing against people that want the ideal to what is the reality, and how do you actually get to there. Then things like consent. You've got to sign a consent form, and I don't think there's anyone from ACI here. ACI has been the Agency of Clinical Innovation, has actually been a barrier to implementing telehealth in New South Wales. They've got guidelines that talk about needing written consent. Now, if you go to any doctor or nurse or anything and have a face-to-face occasion of service, you don't sign consent. It's all implied. You're coming into a hospital, it's implied consent. But this has been an argument that's gone on in New South Wales for a really long time. So there's not a huge amount of training, but it's a matter of having people that can train, people that can support, people that can be alongside and help you through your first couple of times. Then you're generally right. I guess just to sort of change the topic a bit though as well, this isn't an if-else computer idea either, where you either have a face-to-face interpreter or you have Google Translate or whatever. There's going to be both. If I feel a little bit unwell, or I have a pathology test and my, I don't know, white cell count is a bit high, where do I go first? I go to Google and I look something up. It doesn't mean I don't then go to my GP as well, but I go to Google. I've been to the GP who's also looked up Google, as clearly a lot of other people have, to find things out, because it's a resource, it's a library. It doesn't mean that that doctor's not trained or able to have the information, but it's a resource. And we can't fight it, I don't think, and say, no, it can't be used, and no, you can't use the site translation side of it. But we've got to make sure we've got interpreters that can make sure that what's being said is right as well, and know when is right to use it and when is not right to use it.
And I think that speaks to Eva's point earlier about shared libraries and so on being useful resources. And in fact, in the break, people were talking about, checking languages where they have some passing familiarity with, but sometimes they want to have a check of, using machine translation.
Yeah, but the difference is, you access probably websites that publishers or endorsed websites or accredited websites. With Google Translate, you're still in the unknown. And I don't think we're aware of how to properly use it to start with. And the content that you put in it and the output that you get could be remarkably different. You're not talking about one word or just preset phrases or expressions. Sometimes you're talking about a whole paragraph, and when it becomes long and complex,
and you're right, it is. I've been to Shanghai Children's Hospital emergency with a 3-year-old that split his chin open and a lot of blood. I can't speak Mandarin. Yeah. I use Google Translate because there was no interpreters around, and I needed to know where to go, what entrances and things like that. But when it came to the medical consultation, an interpreter came in then, and that was very important around how we were going to do things and other aspects. So wayfinding, I think, is okay. Yeah. When you're going to appointments, when an interpreter is going to come, the clinical conversation around stitches or super glue or, what pain medication a 2-3-year-old's going to have, you need an interpreter.
I think that more complex, yes.
And so I think we're getting to the guts of the message seems to be, how do we positively engage with this and figure out where the boundaries of what's okay and what isn't.
I would like to add that, especially on Google Translate, that with some languages, the accuracy rate is much higher than, for example, European languages, French, Spanish, Italian. So again, we need to be mindful of that sometimes, not to compare
There's
languages.
A lot of variability.
Yes.
Ben, and then I might ask Vesna for some thoughts as well.
Oh, sure. Just really quickly, Ben, you mentioned earlier in your presentation that the algorithms or the software is learning from us, okay? So, there's a machine there and information is entered into the machine and then something comes out the other end, okay? So does excuse my ignorance, because I'm not technically up with this sort of stuff, but we know that things like the Health Translations Directory have got translated information. We know that there are other agencies who have got lots of high quality translated information online. Does Google Translate learn from those things? And does things happen like, and I haven't used Google Translate specifically around a particular health issues, but are there ways to promote existing high quality resources through Google, so you're not actually do you know what I mean? So a user feels like they've got options. If you're talking about using the word wayfinding, so is there a way we can engage, engage Google in order to set up that sort of process?
To pull from already translated.
Exactly.
Yeah.
Exactly. Yeah.
Yeah. So, well, I guess that's sort of a niche question, but I think it's not Google's approach. Their approach is to use the entire corpus of all the languages that exist, online and not. But it is an approach that could be taken, for example, by another agency who wants to develop a more reliable machine translation process using a specific training approach. However, I'm conscious this is a little bit wonkish, and I think I still think we would encounter the inherent problems of neural network type learning, even with an ideal and very high quality training data set. Vesna, did you want to, I'll just check in with everyone for your final thoughts, but Vesna, did you have anything you'd like to add based on what you've heard?
Look, I still believe that, you know, we need to use a whole array of things. You know, we should not be ignoring technology. We should not be ignoring everything that's out there for us. You know, we're well aware of the complexities within our service. We're well aware of our shortfalls. We're well aware of the costs and that. So I think it's about what we choose to use, how we choose to use it. We need to have policies and frameworks established. We need to have training. So all parties concerned, and again, I'll talk about, you know, the public health sector. You know, communicating and training is extremely important from, you know, everybody concerned. We will have patients that will, you know, pull out their apps, which is fine. We can understand that. Even if we choose to, in that moment, you know, go with the app and allow them to use it, but then as soon as we're able to, you know, bring in an interpreter and then, you know, confirm the information, I think is really important. We're not going to be saying to, you know, young male doctors who are comfortable with technology that have really good intentions, and their intention is that they do want to provide, you know, excellent service. They want to ensure that the patients are feeling comfortable and participating. So we're not going to, you know, slap them on the wrist and say, hey, you know, that's against, you know, the policy, which it is. However, but then we can go out there and we can train them. We can discuss, you know, the best mechanisms that are available and the tools that are available to them and the reasons for it. And I think that in some circumstances, you know, it's our responsibility as healthcare interpreters. We go out there to train to enable people to have all of the necessary information and knowledge and know how to access us and, you know, get over some of those myths. You know, it's going to take me 6 months to get an interpreter, or, you know, the communication's going to take, you know, double the time and I don't have that. These are all myths. But then it comes back to us, you know, to communicate that information. It's an ongoing process. As I said, we've been in existence for 42 years, and because we've still got plenty of work ahead, hopefully we'll still all be in a job for another 42 years at least.
Well, that might be a great basis on which to bring the panel to a close. I'd like to invite you all to thank all the panellists for all their comments and input.